Good evening, Dr. MJOM May.
Yes, good evening.
Good evening. I'm sorry for you, the inconvenience.
Yeah, no problem.
No problem. Oh, it was easy to join today.
Yes.
Okay. Did you use password?
Yeah.
Okay. So you need the password. Maybe it is a constant, never changed.
Yeah. Yeah.
Okay. Okay.
Arigatou gozaimasu.
How are you today?
Yes, very fine.
Hi. Are you busy? How about your hospital?
As usual, the COVID, because of COVID, the allergic cases are just starting now.
Just starting.
Yes.
Just starting.
Yeah, not too much cases. We don't do most of the allergic operation. Only the trauma operation.
Only the trauma.
Yes.
Okay. Okay. How about the spine? How about the
spine trauma? We did spine trauma.
On the trauma.
Yeah.
Okay. 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 But in our countries, it's gradually restarted everything because number of patients is decreasing. Virtually no new patient.
Yeah.
But everyone is worried about the secondary pandemic.
Yes, it's the same.
Yeah, so maybe restriction is over. So anyone can move city to city, move to prefecture to prefecture.
Okay.
Yes, but it can cause the second spreading of the COVID. So everyone is very, very careful. See, after the stop of the restriction, not so many people in town or city. Everyone is hesitant to go out to communicate to each other. Okay, okay, Chanta is coming. So, shall I start today's talk? Yesterday I talked about morphological characteristics of Japanese patients. Maybe it is similar in other Asian countries. So I talk about other unstable fracture. Or maybe this is a borderline fracture between femoral neck and trochanteric. The one is basicervical fracture, basal neck fracture, just between femoral neck and trochanteric fracture. It is a fracture between the intracapsular and extracapsular fracture. And currently, because of spreading of 3D CT in Japan, so we found that many surgeons have this type of coronal sharing fracture. Regarding the sharing fracture, the vertical sharing fracture, such like Powell type 3, is very famous. But interestingly, not only the vertical, but the coronal sharing fracture, we can sometimes find on the CT. So sometimes this type of fracture is misunderstood using a plain CT. Only the 3D CT we can recognize this type of fracture. For example, this patient, the fracture line in the anterior side is here, the lower end of the femoral neck. But in contrast, in the posterior wall, fracture line is just below the femoral head. So just like the oblique fracture. So base of one side is base of neck, in another side just below the femoral head. It is still very unstable. So sometimes, so in the past, even in Japan, 3D CT or even CT is very, very difficult to use routinely before or after trochanteric fracture. But currently, every hospital has one or two CT machines. So it's quite easy to evaluate the type of fracture on the CT scan. So maybe I always said about the Japanese special situation. In Japan, MRI and the CT is very, very popular. Most hospitals have both. So it's quite easy to analyze three-dimensionally. But before the spread of CT and MRI, even in Japan, only the X-ray, AP, and lateral view is the only tool to diagnose the femoral neck or trochanteric fracture. So on the plain CT, this type of fracture we cannot find using this former X-ray system. We need 3D system. So after the fixation, the fracture, we believe the normal trochanteric fracture, maybe some case should be this type of fracture, coronal sharing fracture. That fracture stability is not enough. Many patients of the coronal sharing fracture, after the internal fixation, the femoral head can displace or rotate. So it is quite difficult to how to fix this type of fracture. So this is the difference. This type of fracture is different from the normal subcapital fracture because the bone cortex of the femoral neck is already broken. It is quite very, very important to give the stabilization after the pinning due to the calcar buttress. However, this type is no calcar because this area is already broken. But it is quite difficult to fix using the devices for the trochanteric fracture because lug screw is too big to fix the femoral head. So regarding to the femoral head fixation, it is quite similar to the femoral neck fracture. So there are very, very small areas to insert the pin or screw. On the contrary, so the fracture stability is quite similar to trochanteric unstable fracture. So it is a mixed type. So this type of fracture has the both difficulty, the femoral neck fracture and the trochanteric fracture. So it is still challenging to fix securely to this type of fracture. So to improve the fixation, this is the German implant from the S Club. It's called Targon FN, Targon Proximal Neck. Chanta Have you seen this device?
Yeah. No.
No.
I never
How about
seen.
the copy implant from China?
Yeah.
No?
Yeah. No.
No copy
No.
device. Okay.
No.
Okay. This is a very interesting. Just like the dual SC, this plate has the small side plate, but two screws, two cortical screws, and for the femoral head, so 4 pins can be inserted into femoral head. And interestingly, each screw has barrel. So the barrel is fixed to the side plate. So this barrel has the slit and screw and lock to this side plate. So we can insert 4 screws into the head. Each screw can fix to the side plate. So it is quite strong to fix the femoral head using the 4 screws. And in addition, this is only one device to fix the femoral head using the 4 screws. Or maybe this angular stability is better, and it can also allow the sliding that can improve the fracture union. Furthermore, this has the 4 screws. It is quite effective to fix the femoral head. But the problem is this distal screw, this cortical screw is locking. So we can change the direction of the screw. So in addition, this screw arrangement is asymmetrical. So this is the one side, this is the left side, and this is the right side. Interestingly, this implant has 2 screws. The direction is different. So if we use this implant for the left hip fracture, this long screw can be exposed to the opposite bone. So this is sometimes injures the neurovascular. So it is quite very risky. In addition, this screw arrangement is a problem because the width of 2 screws arrangement is 24.7 millimeter. I also told about the morphology of Japanese patients. The average width of the femoral neck was 21 millimeter. So it is too big to fix femoral neck fracture in the Japanese patients. Maybe this is manufactured in Germany and originally developed for the German patients. So Japanese size was not taken into account. So this is another problem. So it can cause easily extraosseous infection. About this, the reason of this complication, I also told yesterday or day before yesterday. And in addition, so in theory, these screws can slide simultaneously, but their ST screw can act the sliding mechanism quite well because the sliding length, so in other words, the shortening of the neck is increasing with the week. but tango is stationary, not change after the fixation. So it means the four screw fixation prevent the sliding of screw. So, but it is still controversial. Sliding is benefit or disadvantage for the bone union and for the patient. If we allow the sliding after the fixation of the femoral head, it must cause the shortening of the femoral head. So eventually, leg length discrepancy can occur. Maybe it is not too much, but maybe 1 or 0.5 centimeter or 1 centimeter shortening can occur. But in contrast, if we use this screw system, sliding never occurred. Maybe simultaneous sliding of the four screw is quite difficult. So it is quite difficult, technically difficult to insert the pins parallel to each other. So maybe only the two pins insert parallel is not so easy. But to insert three pins in the parallel is quite difficult. And for the four screws, it is virtually impossible to insert the parallel to each other. So maybe this is also the main cause of this lack of sliding after the operation. But the sliding is prevented, but it can also prevent the leg shortening of the after the operation. I don't know which is the better, but we should recognize the difference of characteristic of two implants. So this is a new type of Hanson pin. So this is 3 Hanson pin is locked to this symmetrical triangular plate. There is no cortical screws. The purpose is to fix the femoral head using the 2 pins to the 3 pins. The classical, the normal Hanson pin, we always use the 2 pins. Because initially, this company and some faculty of this implant insisted that 2 pins is enough. We never need the 3 pins. So they chose the biomechanical to study and show that the 2 pin and 3 pin is no change of the bone stability after the operation. But this version, they changed their policy. Use 3 pins. Of course, inside the 3 pin is very strong to fix the femoral head. And so connect 3 pins using this screw. Its 3 pins act as one piece, 1 pin as a 1 pin. So it can strongly prevent the chopstick rotational displacement of the femoral head and synchronize the sliding. It is quite famous. There are famous complications after the 2 pin fixation of femoral head. Chanta, do you know the name of complication after the 2 pin fixation of the femoral head? It is some kind of backout. Do you know? No. Okay. Okay. Maybe my question is not so good. So maybe my question is not good. We call it I forgot. Oh, please wait. I forgot the name.
Yes.
I didn't know. Please wait. I will. Okay, I will. Okay. I'm sorry. Suddenly I forgot the name of this complication. This is the 1P is going forward, and another P is going backward. So one is advanced, and the another one is go back. So this is the kind of the back out. So prevent this complication. This we call it hands-on pin lock. It's connected the 3 pins on this same plate. So, but it is quite bulky. So like this. So during the sliding, this big plate also slides the backward. So sometimes patient feel pain or discomfort due to this big plate. So it is also very specially used in Japan and Sweden. Maybe no other countries, no surgeon have seen this type of implants. Maybe. But in Japan, this device is very popular to fix the femoral head because many Japanese surgeons believe the hands-on pin is the best device to fix the femoral neck fracture. Okay. Yeah, I'm sorry. Wait. Okay. So if the femoral neck is over, this arrangement for the hands-on pin lock is proper. But in fact, as I said yesterday, the cross-section of the femoral neck is not oval, but triangular. So if the pin is inserted following this arrangement of this hands-on pin lock plate, the superior posterior pin can insert it outside of bone sometimes. Furthermore, so this is the targon arrangement of the targon. So that have the 4 screws. It is more impossible to insert the narrow Japanese patient femoral neck. So we devised the new type of implant. So that needs the angular stability, that needs the fixation system that has the side plate and 3 screws to fix the unstable fracture, such as basal neck fracture and the coronal or vertical shearing fracture. So to prevent the femoral neck rotation and femoral neck displacement, so we need 3 screws to fix. And it should be the anatomical. So in other words, that means the arrangement of the screw should take into account the anatomical characteristic of the femoral neck and femoral head. So as I said yesterday, the anatomy and the morphology of the femoral head is very complex. It is bent anteriorly and the cross section is triangular. So we calculated the best screw arrangement for the fix the unstable fracture between the femoral head and the trochanteric fracture. So this arrangement should be, this is the proximal and this is the distal. So this is the distal pin. It should be the bottom of the femoral neck. And then this is the anterior superior pin that has a wide distance from the distal pin. And third pin is the posterior superior pin. Unlike the Hanson pin lock, this pin is not displaced posteriorly, not so much displaced, only the 3 millimeter from the distal pin. So we believe we calculated this arrangement is the best to fix the femoral neck. And then we calculate the average Japanese neck shaft angle. That was approximately 126 degrees. So we consider the variation of patient to patient. We devised this one, TresLock. So this is for the femoral neck fracture, especially for the unstable fracture. One is the vertical shearing fracture, and coronal shearing fracture, and the basicervical fracture. This is just between femoral neck fracture and trochanteric fracture. The arranged screw arrangement is that one. So referring our anatomical study, so we arranged 3 screws like this. One is the bottom is the distal pin. From the distal pin, the making the 27 in the angle anteriorly, and the distance from here, the 6 millimeter. That is the point for the anterior superior pin. And posterior superior pin is apart from the distal pin, 20 millimeter, and 3 millimeter displaced posteriorly from the distal screw. And neck shaft angle was 128, just between 125 to 130. And this is the short thread. So we devised. So that has a double taper. The one is this one. The thread thickness is thinner in the tip and the thicker in the base. The thickness is increased gradually to the end base of the screw. So this can act as a compression of the surrounding bone. The compressed bone can help the secure fixation of the screw head, even in the osteoporotic fracture. In addition, not only the thread but also this stem of screw is also tapered. So during the insertion, this taper shape can compress the bone around the screw, so that can fix the screw very, very securely. We compare the mechanical pull-out strength of the normal screw, 2 centimeter screw, and this new device screw. The pull-out strength is stronger in this 15 millimeter, the double taper screws. This is another innovation. So this is a very old paper. This is maybe this report is around 2 years before. So maybe the patient number is increasing. So this is the cross section. So as I said yesterday, so this cross section is not oval but triangular, but screw is perfectly inserted within the medullary canal of the femoral neck, like this. So other hospitals studied like this. The different result was similar. All pin can be inserted within the femoral neck. So it is quite interesting and quite convenient. Once we insert the distal pin here, then another pin is the location and direction is decided automatically. So automatically, 3 screw is properly inserted into the femoral neck, and of course in the femoral head. So I think it is quite convenient. In addition, so this screw is 128 degrees. So it is quite similar to the patient's original neck shaft angle. The difference was only the 2.8 millimeters. It was virtually parallel to the patient femoral neck axis. Sorry. In addition, so I also evaluated the distance from the subcapital line and the thread end. The average was around 1 centimeter. So also this short thread acts very well. So this case report, this is a 79-year female. This is after the operation. It is quite well. The fixation was quite well. And this is a 3D CT. It was inserted a very good place within the canal. And it comes a little bit distal anterior. So maybe the reduction was not enough. Maybe in some degree of retroversion. It is still reducted. Okay, the second one is like this. This is the typical vertical sharing fracture. It was fixed very well using this device. And again, arrangement was very good. But sadly, there is some protrusion of the screw head. Maybe it is the anterior superiority. But maybe this pin head is still within the cartridge. So this patient heals and event-free. So like this is also vertical sharing fracture. In fixed stability was very well. and insertion was perfect, and arrangement was perfect, like this. So this is a conclusion. There were TresLock has the angular stability and keep a parallel because the screw is fixed on the plate. But synchronized sliding is achieved only the Hanson beam lock. The TresLock screw can slide independently, and the Targon FN as well. Okay, but it is only available in Japan. But this concept is very interesting. So please remember the characteristic of the femoral neck or the morphology, especially the cross section. It is not the oval, but a triangle. So I recommend to insert a pin and the distal and superior and a little bit posterior. Not too much, never too much, but only a little bit. But if you insert anterior superior, so you can keep the big distance between two screws. And in the lateral view, if you insert the pin from the center of the femoral shaft, aiming to the femoral head center, this line should pass the posterior in the femoral neck. So this is a very unique morphological characteristic of the femoral head. Okay, please remember.
Right.
Okay, this is the end of my talk. Do you have any questions or some comments? It's all right?
Yeah, it's all right and very clear.
Okay,
Concept.
thank you. Thank you. So maybe tomorrow I will talk about trochanteric fracture. I also devised a new device for the trochanteric fracture. So I will explain about the trochanteric fracture, especially the Japanese strains. So because in Japan, so many trochanteric fracture patients because of aging society. So many doctors are interested in the management of the trochanteric and the femoral neck fracture. So analyze and study of the trochanteric fracture is very, very detailed. So it must be very interesting. So see you tomorrow.
Yeah,
Yes.
thank
for
you.
joining. Thank you. Bye.
Bye.
Bye bye.
Bye-bye, Professor.
Bye.